Can everyone? Yeah, hopefully everyone's able to see this. Yeah, so as Jorge has mentioned, my case study is about working clinically via telehealth with an asylum seeker that's experiencing self-harm and suicidality. I chose to present this particular case because the primary form of therapy with this client was via telehealth due to COVID, and it's quite a complex presentation. The client has a history of self-harm and suicide attempts, substance use and auditory hallucinations, and this is all in the context of an unresolved visa status and his federal court appearance. And hopefully my presentation can demonstrate some of the strengths and difficulties of phone counselling as a modality for asylum seekers that are in a state of protracted uncertainty. Now, I'll just put this into the broader context, but Australia really is in the middle of quite a mental health emergency. And according to modelling predictions, this comes from the Brain Mind Centre actually, they have predicted something quite alarming, that over the next 5 years, we could see suicides increase by from 750 to 1,500 additional deaths per year over the next 5 years. This is due to the secondary crisis sparked by COVID-19. But what about some of the other vulnerable populations in Australia, such as asylum seekers who are already at such an increased risk of self-harm? What we know about asylum seekers and their risk of suicidality is that rates of self-harm among detained asylum seekers are already 376 times higher than that of the general Australian community. And that's statistics that come from Foundation House, our sister organisation in Victoria. And also, according to our own STARTS data, since the beginning of the lockdown last year, we found out that asylum seekers are almost twice as likely to present with suicidal ideation that's compared with clients with their permanent residency already granted. So now I'll just introduce my client, and I have changed a lot of the demographic details just to protect his confidentiality, of course. I'm going to call him Samir. He's a 34-year-old male Persian. He was born in Tehran, Iran. His language is Farsi, and he has actually very good English, but he does prefer an interpreter for our phone counselling sessions. And he was raised as Muslim but converted to Christianity. And there's limited information provided about his family of origin and early childhood. And he is on a bridging visa E, and this bridging visa allows someone to stay lawfully in Australia while they finalise their immigration matter or make arrangements to leave. And he's awaiting his decision from the Federal Circuit Court. We might call this a double negative pathway. I've seen him for 21 telehealth sessions so far and 3 face-to-face sessions. The dates are there. And I also supported him in person at the Federal Circuit Court. That was just recently. Again, my client's quite reluctant to speak too much about his early childhood, but I've put this here by way of a genogram. You can probably draw some inferences from this diagram. I will just say that he is the only one of his family members to be residing in Australia. His extended family are all back in Iran. I will mention as well that his father is Azeri and his mother is Persian. And there is a lot of conflict between them. They're of different ethnicities, which might be impactful. This is some very interesting information that did come out. The client reports severe early childhood abuse. He says that my father put me in a cage in my own home. He smashed my head and face so I could not eat or drink except through a straw. However, his mother, he's a strong bond with her. She's quite a protective factor, and they are in regular communication via WhatsApp and video calls. So I'll just explain some things regarding his experiences in his country of origin. In Iran, he was given 70 lashes for drinking alcohol, and he was targeted by the morality police in Tehran because of his hairstyle and objections to Islam. He underwent compulsory military service, but during that time it actually led him to discover Christianity through some friends, but he was shot at after his conversion, and he began his boat journey in 2013 at a very young age, 24, and he spent some time in detention centres, as is recorded there. He has quite a long history of suicide attempts that even began at the young age of 17 or 18, where he began to overdose on sleeping pills. Then again at 22, he tried to jump off a bridge. They continued in Australia, where he was scheduled in 2019. He also attempted to hang himself from a tree in a park, and he was only rescued by a passerby. He was also self-harming, hurting his head with a knife and hospitalized. And again, when I began to see him, he was self-harming again and hit his head and, had to be scheduled at that time as well. I will mention a little bit about auditory hallucinations, or we might like to call them pseudo hallucinations, because the client is aware that they're not real, that they're not his own voices inside his head, they're external. And they're quite diverse in the nature and the number of voices. He says they talk about many things, everything, not just one thing. Sometimes they are commanding, sometimes they're familiar and unfamiliar, and sometimes he's more vulnerable to these voices when his mood is low. The onset was about 12 to 18 months ago, and it's likely triggered by crystal methamphetamine's use, but we also know that is highly likely to have a traumatogenic component to these voices as well. Regarding his substance use, I did mention that he was using crystal meth or ice, also marijuana, but they were used for self-medication, but he did manage to stop this use as he realized his mental health was deteriorating. And he is currently under the care of a psychiatrist, which is great, who's prescribed antipsychotics and antidepressant medication. Now at STARTS, we like to conceptualize things in terms of a biopsychosocial model. There's a lot of symptoms here that I've mentioned, but I will just draw your attention to a few key issues, which were the hallucinations, as I mentioned, low mood, shame and avoidance, and social isolation. They were some of the ones that I just want to highlight that were quite severe in Samir. Now, Maxine's also shared how much information that we can try to get over the phone. And this is something that I did by way of a mental state examination. These are the things that I was able to gather by my phone conversations and therapy sessions with him. For example, the quantity of speech was quite minimal. This can be associated with depression. The tone and volume of his speech was also monotonous, which can also be associated with depression. His mood, he reported to be low. His affect was flat, but it's congruent with circumstances. The flow and coherency of thoughts were quite steady and logical. His insight was quite good. As I mentioned, he was aware that he was having these auditory hallucinations. He was well oriented to time and place. And I will just make mention of the fact that he had quite low attention span when it came to therapy sessions on the phone, and he wanted to have a Farsi interpreter present if the sessions went over 30 minutes, which is generally what they did. And absolutely, we provided that for him because it's so much easier to speak in your mother tongue with counselling sessions. Yeah, and when I met him in person in the office, I invited him to come and meet me a few times as he was able to travel, because even as an asylum seeker, the cost of a $4 train ticket might be like an enormous amount for them. I was actually surprised that he was very well groomed, very neatly dressed, his hair was done. It was very appropriate in his behaviour, and he was able to establish quite a good rapport with me, with good eye contact and engagement. So that was quite interesting. Also at STARTS, Aroach and Hoelo have developed this model, which we use to describe the complex interaction of challenges that our clients face. I'll just draw your attention to the 3 intersecting circles. First of all, each client that we see comes to us in the context of their normal life, in the normal life cycle. So we're talking about a young man in his early 30s who's unmarried, unemployed, unable to get an education, no study rights, who's disconnected from his family. And there's a whole range of challenges that apply to someone at that stage, let alone all the trauma reactions that impact him. And those are the ones that I mentioned earlier. And also we've got, as an asylum seeker, he is seeking protection, and there's like a lengthy legal process that lasted over 7 years. There's challenges with the language and welfare payments and all kinds of issues that are specific to an asylum seeker trying to find some sort of certainty when they're living in protracted uncertainty. And this all happens on the backdrop of the Australian environment. And how many of you know sometimes the Australian environment can be more or less hostile towards refugees, particularly maybe from Middle Eastern background, or may have all sorts of perceptions. So that's really important to acknowledge that this happens in context. And I don't even need to make mention of, but I will, the fact that COVID has impacted us, creating such a sense of collective anxiety, especially among those that are already vulnerable as it is. And being from Iran, you might be aware how Iran was one of the countries to be affected earlier on, quite with devastating impacts from the pandemic. That's where his family are from. So yeah, this is just a great model to capture everything, to show how complex this case and all our cases at Stance really are. So now we'll move on to showing some of the interventions that I used using the telephone modality. And anyone that works in the trauma space will be so familiar with the absolute importance of establishing safety. Judith Herman talks about this in her seminal work, that we can't move on to any further work in trauma processing until we've established internal and external safety. And I love, as Maxine speaks about, the person-centered approach. That is really essential. I like to use that, very attachment-based, attachment-informed. So for me, the therapeutic alliance works as a secure base, and from that holding environment, everything else flows. But establishing safety might be prolonged due to the fact that the client is a danger to himself. It might sound so basic, but we also know that trauma and torture survivors don't have that internal control and don't feel safe in their bodies because they've been so abused. And so it might sound very simple, but issues of bodily integrity like sleep, hygiene, exercise, eating, maintaining abstinence from substances, that sounds so basic, but they are really foundational. And moving on to establishing external safety, again, Maxine mentions this in her book. She says that greater equality in the client-counsellor relationship when it develops over the phone, because the client is in their own familiar place, which is established as a sense of safety. And so we have a lot of conversations around the living situation, like where Samir's living with a housemate, if he feels safe, removing access to means, and just really identifying his behaviours that are self-destructive. I love this quote from Judith Herman, and I copied it in its entirety. She says that many self-destructive behaviours can be understood as symbolic or literal reenactments of the initial abuse. They serve the function of regulating intolerable feeling states in the absence of more adaptive self-soothing strategies. The patient's capacity for self-care and self-soothing must be painstakingly reconstructed in the course of long-term, individual or group treatment. And that's exactly what I try to do, trying to provide more adaptive self-soothing strategies. And for me, a natural modality that does this is dialectical behaviour therapy, or DBT, developed by Marsha Linehan. So within that, she has one module called distress tolerance skills, and they assist the client navigate through their crisis and avoid destructive behaviour. So trying to lower the intensity of his pain, then we can move on to other coping skills. There's a lot of great research to support the efficacy of using phone counselling with clients like Samir, like with suicidal issues and non-suicidal self-injury and substance use. And what's quite interesting is that actually phone counselling promotes the generalisation of skills to the patient's real-world context. And DBT, if you're familiar, has lots of diagrams, and these were sent to Samir as a visual reference, like as an SMS. That was a suggestion again from Maxine in her book as well. So with Samir, I went through a number of these skills, and you'll get a copy of these slides, so I won't explain all of them, you can look into them, but they included urge surfing, which you might be familiar with, is like teaching him that like pain and these overwhelming feelings can like feel totally overwhelming, but they do peak, and then we have to sort of ride through that intense urge to harm yourself, knowing that they will later subside. Teaching other self-soothing techniques, using the stop skill to stop engaging with impulsive behaviour. Speaking about conversations around radical acceptance, which was really important, especially in the lead up to his court, and will continue to be implemented until we get this verdict. Distraction techniques and improve the moment. Again, this is an acronym that relates to things, but one of the aspects is prayer, and the P in stands for prayer. And I make this very culturally relevant for him, utilizing the coping skills that he's used to from his family and religion. And it's very important whenever we use Western-based modalities to make them as culturally relevant for our clients who may be new to the concept of counselling altogether. Another modality which I drew from is compassion-focused therapy. And this is very effective for voice hearing phenomenology, actually. The article by Harriet Mainland that I've quoted is in my references, and I really recommend just looking at it. It's so dense with information. And so compassion-focused therapy helps to understand the function of the voices in its context and shift towards a safe and compassionate orientation. So in practice, I would try and get Samir to inviting him to consider and practice how he might wish to relate to himself, his voices, and other people from the position of his compassionate self. And it's suggested that repeated practice of creating internal patterns of safeness and compassion can lead to affect regulation, emotional resolution, and therapeutic change. And it involves bringing to mind remembered and or imagined compassionate relationships with others. So what I spent a lot of my time doing with Samir was trying to strengthen his social supports, his connection with his family in Iran, or his church, or the Farsi-speaking community here, and other support workers that he had. It also involves appreciation exercises and trying to emphasize the things that a client enjoys. But the aim is not necessarily to eliminate voices, but to make them easier to live with. And with Samir, sometimes he struggled to engage about this issue. Like, he didn't want to talk about his voices all the time due to fatigue and avoidance and just feeling overwhelmed. And so these interventions proceed at a pace that is comfortable with him. Again, because the premise is based on respect for the client's wishes at that time. Other strategies, things that I utilized was behavioral activation, which is like behavior experiments to sort of increase his mood, even something as simple as like walking every day, and motivational interviewing, again, a good strategy for relapse prevention. A lot of case management, and anyone that works at STARTS, especially with clients who are asylum seekers, knows that that's a very important aspect of our work, liaising with his mental health workers, GP, psychiatrist, and RACS lawyers, and also referrals to the community mental health emergency team when required. So that happened twice over the course of our sessions, over our therapy, when he was quite suicidal at high risk. Now at STARTS, we also routinely deliver the Harvard Trauma Questionnaire and Hopkins Symptom Checklist by way of psychometric assessment. And there's a lot of things that you could probably read into this graph. You can kind of see that we have got a slight increase in his depression and PTSD, and they're still very much at a clinically significant threshold. And the anxiety symptoms have leveled off a bit and decreased, still significant. But I do have to just re-emphasize that this is such a severe case. Again, we've got a client that has had multiple lethal attempts of self-harm and suicide attempts. Again, if it wasn't for that passerby at the park who stopped him from hanging himself, he may not be with us today. So it's very serious, and the case is still very much unresolved, and the threat of deportation to Iran and facing his death is very much there. So I feel like the trauma and the depression is still with him very acutely. What could be interesting is, with a slight decrease of anxiety, I'm thinking that perhaps he's been able to implement some arousal reduction strategies or distress tolerance strategies. So that's some thoughts to read into. But again, this case is very much ongoing. And it kind of leads me to the next slide, which is such an important aspect of our work. Maxine's spoken about this, and I will as well, from my experience of transference and counter-transference. I'm very aware of the attachment dynamics. We all have to be aware of our clients' dynamics, and as a therapist, what our attachment styles are. And I'm quite conscious that my client Samir is on the avoidance side. So he'd rather have less phone calls rather than more. And if I'm honest with you all, my style is a little bit more ambivalent. So checking in, needing that reassurance that he is safe, wanting to reach out more. And so having like regular weekly Friday 4 p.m. sessions has been a really good boundary to keep, so that we just ensure that that's something that's stable and consistent. Again, I did mention that it is very severe and it's very lethal attempts in the past. And actually a few years ago at another clinical presentation, Guy Coffey from Foundation House, I think he's a lawyer and clinical psychologist, he spoke about, you know, clients facing deportation. And he used the word diabolical to describe it. And that stuck with me all these years, because it truly is a diabolical situation, working with someone who has a, sadly, very high chance of being deported back to a place where they're very likely to be imprisoned or tortured or killed. So I just wanted to mention that sometimes we forget, like, this is the nature of our work. It can actually be diabolical if someone's facing that. So again, it's feelings of helplessness, powerless and injustice in the context of working with asylum seekers and the federal court when they're at that level of a double negative pathway. And finally, yeah, as I sort of mentioned some of the outcomes, but it's so ongoing when you're working with a client still waiting to hear the verdict and highly at risk of deportation. We might have up to 6 months till we hear that verdict. But I feel so far that we have achieved a very strong rapport over the phone modality and maintaining good boundaries and consistency. He's been abstinent from all his substances, so he hasn't used drugs to self-soothe. So hopefully something's working for him. He's got some improved management of his voice hearing phenomenology. He's got a strengthened connection to his mother. And actually, Professor Nick Bendit, who's a psychiatrist at the Centre for Psychotherapy in Newcastle, speaks about this as like how to strengthen their connection to their loved ones by having visual cues all over the place, like their phone, so photos of his mother everywhere, so that when there's a risk of harm, he could suddenly be reminded of people that care for him and love him. I've also hopefully strengthened the connections that he has with his healthcare workers and other professionals. And there has been some sense of stability. So there's been no self-harm since September 2020. And he does display to me an ongoing commitment to refrain from self-harm. So these are it's very much a work in progress, but this is our work so far with Samir. So thank you all so much for your attention tonight. And I've attached the references at the end for you.